So this next category are a group of drugs known as the direct inhibitors of thrombin. And so they actually, in terms of their mechanism, they actually interact and then inactivate um, both free thrombin, so thrombin floating around, and then thrombin that are already involved in a clot that are bound to the fibrin protein molecules. And so this group of drugs basically directly and reversibly bind to the active site of thrombin and only thrombin. And it's interesting. So these are the group of drugs that were originally discovered from the medical leech, okay, shown here. And so they've been kind of improved upon over the years and over the generations. Um, there's two subsets, the bivalent and the univalent. I'm not sure how clinically relevant that is, but I did put it in here just in case you come across it in the literature. Um, the bivalent drugs basically bind to both the active site and another allosteric site called exosite 1, whereas the univalent molecules basically just bind to the active site. And again, I'm not really sure if that's clinically relevant, but at least you've heard it once. I don't intend on testing you on that. I don't think it's that important. So in terms of those bivalent drugs, and I guess the only really good reason is to further subdivide them into something, which includes lepirudin, bivalirudin, and desirudin. And then the univalents are your gatrobans. So argatroban, dabigatran, and meligatran. And so these drugs are actually, they were called the novel oral anticoagulants, and there was uh, an acronym for them. I think it's NOACO, NOACO, if I remember correctly. But everybody just calls them the novel agents. I think out of default. So let's look a little bit more in detail. So lepirudin has been used historically for the treatment of heparin-induced thrombocytopenia, but it's no longer available in the U.S., so that one's out. Really, the two that you should be familiar with are desirudin and bivalirudin. Desirudin, again, for the prophylaxis of deep vein thrombosis and patients undergoing knee and shoulder replacements. Bivalirudin has been used in procedures. Patients that have a history of heparin-induced thrombocytopenia that need kind of like an emergent coronary angioplasty or PCI, these patients would be really well suited to bivalirudin. And it's really kind of been more clinically used because we've identified patients who have had heparin-induced thrombocytopenia because they were given heparin for an earlier surgery, and heparin for these patients would be contraindicated. So all the patients that would fall into that category, any type of anticoagulation you would need would be indicated for these particular patients. This has also been a really good anticoagulation for patients with unstable angina who are also undergoing PCI. And then now they're looking at studies about using this agent with an aspirin and a glycoprotein 2B3A inhibitor, and seeing which is kind of the better in terms of clinical outcome ways of managing some of these patients. So I think you'll probably see a lot more of this in the next 5 to 10 years. And we said that this is one of those direct thrombin inhibitors bivalirudin. It's got two binding sites. And of course, this is a reversible process, which is good. So, you obviously want to maintain anticoagulation during the procedure and shortly thereafter. But of course, when you stop the drug, it's essentially gone. It's got a short half-life, and this is given IV, which is great. The dabigatran, which is kind of the second generation or the univalent drugs, was really kind of the first oral administered direct thrombin inhibitor that was on the market back in 2009, which seems like it wasn't that long ago, but I guess it was. We're already 2018. And you can see dabigatran used for the AFib patients that have essentially normal valves. The dosing is based on the creatinine clearance, and of course there are some drug-drug interactions in terms of P-glycoprotein inhibitors and CYP inducers and inhibitors as well. So in terms of kinetics and dynamics, dabigatran's absorbed um, as an ester, and then it's hydrolyzed. The bioavailability is quite small; it's only 3 to 7%. And then a third of the drug is bound to plasma proteins. The half-life is about half a day, and then it's renally eliminated. Argatroban is another kind of molecule in that same category. It's administered IV, however. It's a really small molecule in terms of its anticoagulation abilities. And this is one that's been an alternative now to hirudin, which was discontinued for a variety of reasons, mostly due to side effects and toxicities, and the fact that they had newer and improved higher generations of these drugs kind of going through the market, so there was no need to use hirudin. And again, it's really for those patients who need anticoagulation for something like PCI or something, but have a high risk of developing heparin-induced thrombocytopenia. So we wouldn't want to use heparin in those patients. So all of these drugs are basically alternatives to heparin for short procedures, essentially. And that's really the end of this particular section, looking at the direct thrombin inhibitors. Let's stop here and we will resume the next section. Thank you.